cutting-edge research, cutting-edge clinical work that we look forward to presenting to you tonight. We're going to be live at the Barry Health Center. So we're working on our video conferencing. So those of you in Barry, welcome. We also, you're not hearing voices. And I also want to thank, in the front row here, Jessica Josephson, who comes from our local Access TV 13, the public station, who's taping tonight's event, and will be playing parts of it at different segments in the future. And so we really appreciate, because it's another way to keep the message out there, because people need to know they're not alone with depression. They need to know what kind of treatments are out there, that there's hope, and that there's even newer ideas and newer approaches that are coming out that we'll be talking about some of those cutting edge treatments, because depression is the second most chronic condition in the whole United States of any kind of problem. It makes every medical problem worse, so the outcomes are a lot worse. So it's very important that we address it. So I also want to thank this evening's media sponsor, WICN Radio, for also their involvement. There's lots of people to thank, but I'm going to pass the baton on to the Vice Chair for the Department of Psychiatry, Alan Brown, who is a lead clinician in the area, one of the best doctors of America, and he's going to keep the ball rolling.
Thank you, Doug. Welcome, everybody, and welcome to my new friends in Barry as well. I'm delighted to have the opportunity to welcome you to our Be Mentally Well series on depression this evening. I look forward to hearing from our faculty about what is new and different in the treatment of depression. But before we do, a few comments to remind us about what is old and common about treating depression. As someone who, like many of you, who has known depression as a patient, as a doctor, as a friend and a family member, there are a few things that stand out about depression in all of its variety. It involves suffering, and it is in fact, unlike most conditions, almost totally defined by suffering. If you ain't suffering, then you're probably not depressed. And it is a suffering of a peculiar nature that seems disproportionate to the circumstances. It goes on too long, too deeply, coloring other aspects of life and functioning. And it is a suffering that doesn't respond easily to the usual efforts to lift human mood, be it reassurance, a Red Sox game, dinner with friends, maybe not all Red Sox games, achievement, love, prayer, a poem, and so on. The good news is that most depression will eventually respond to a host of interventions that also have a few things in common. Some of these interventions are medical, but some are not. Depression responds to change and sometimes demands change of us. It may be a change in medications, but sometimes it's a change in circumstances, a change in thinking, a change in our behavior. Personal growth, and Aristotle actually thought wisdom can be the consolation prize for depression sufferers. Although it's not an education I would readily recommend to anyone. And depression sufferers tend to respond to being understood regarding their difficulties, while at the same time we maintain hope for change when our fellow sufferers cannot readily grasp it. And while I like to be the therapeutic agent of change, as I grow older, I'm also happy to be the observer of it as patients and families come up with their own recipes for recovery, as do students and residents and sometimes even Oprah. So tonight, it's nice to hear about what others have to say about depression, how they treat it and how they live with it. And I'm hoping our department can be helpful for those of us in our community who know this condition tonight and going forward. So thank you so much for coming. Let's start to hear from our speakers. And first, Laura Myers, our Associate Director in Community Development and Parent Engagement and many other hats.
Right.
We'll introduce our speakers.
Right.
Thank you, Laura.
Thank you, Alan. I also want to thank you all for being here this evening. And thank WICN Radio and thank WCCA Channel 13, TV 13, and also welcome to the Berry Health Center folks who are sitting there. Many people ask a basic question: where are the restrooms? If you go out the back door upstairs or around the corner, they're right out across the hall. The questions, we have plenty of time for that. We're going to be hosting them at the end of everybody's presentation, so please jot your questions down and don't forget them because we will have time. If you miss the exhibits downstairs, they're right near the registration table and they will be up at the end of this evening, and they're also coffee, tea, and other goodies, and we invite you to enjoy them. Our evening begins with Dr. Anthony Rothschild, the Irving S. and Betty Brudnick Endowed Chair and Professor of Psychiatry. He's also the Program Director of the Depression Specialty Clinic, the Director of the Center for Psychopharmacology Research and Treatment at the UMass Medical School and its clinical partner, the UMass Memorial Medical Center. Dr. Rothschild has spent more than 25 years in both clinical and research settings, diagnosing and treating patients with psychotic depression and studying the diagnostic challenges, biology, course, and treatment of the serious disorder. He has published his work in numerous scientific journals, and his latest book is the Evidence-Based Guide to Antipsychotic Medications. Dr. Rothschild is a distinguished fellow in numerous American and international psychiatric, psychopharmacologic, and neuropsychopharmacologic associations. He has received many research grants and has presented at numerous local, national, and international meetings. He is on editorial boards of many psychiatric journals and has received numerous awards and honors. Dr. Rothschild received his bachelor's degree from Princeton University, his medical degree from the University of Pennsylvania School of Medicine, and did his psychiatric residency at McLean Harvard Medical School. And it's my pleasure to welcome Dr. Rothschild. It's all working. Okay, so here you go.
Well, thank you very much, Laura, and thank you all for coming this evening. Sometimes when I'm in a social situation and people ask me what I do for a living, I tell them, I'm a psychiatrist, and they ask, well, is there anything you specialize within psychiatry? And I say, well, I've spent the majority of my career specializing in the treatment of depression, serious depression, treatment-resistant depression. And I always get this reaction that how could anyone do that? How could anyone sit all day and talk to people who are feeling depressed? Now, I immediately recognize this is someone who doesn't understand that it can actually be very gratifying to work with people who suffer from depression. And, having done this for a while, I can tell you there is no more grateful patient that I've ever seen than someone who has had depression and you do something that makes them no longer have depression. There is no more grateful person in the world. And on the other hand, it's a very serious condition, and unfortunately at times can be a fatal condition because sometimes people with depression give up hope and commit suicide, and then of course there is no longer a chance to help them. So what I'd like to do in the brief time that I'll be speaking this evening is talk a little bit about the recognition of the signs and symptoms of depression. Before I do that, I just wanted to disclose to you that I'm a consultant for a number of pharmaceutical companies. I receive research funds from you, the taxpayers, through the National Institute of Mental Health, from Cyberonics, St. Jude's Medical, and Takeda. I invented a scale to measure antidepressant tachyphylaxis, which is a fancy way of saying when antidepressants stop working, or as some people call it, antidepressant poop out. So far, I've made $300 for that. And as you heard, I've written a number of books, and I actually have a book coming out later this year called The Evidence-Based Guide to Antidepressant Medications, and these have all been published by American Psychiatric Press. Now, one take-home message this evening is that this is a common illness. And fortunately, over the last 20 years, people have talked about it more. So there are well-known public figures in political life, in Hollywood, in sports, who have talked about the fact that they have suffered from depression, been treated for depression, and have gotten better. And so it's not one of those things so much anymore that people think that they're the only one who suffers from depression. But I think it's still important to emphasize that it's a common illness. About 20 million people in the United States at some point in any given year will suffer an episode of major depressive episode, which I'll show you in a few minutes how that's defined. 1 in 6 American adults will experience depression at some point in their lifetimes. 20 to 25% of women are at risk for major depression in their lifetimes, and 7 to 12% of men. It's interesting, whenever studies are done about gender differences, it's always found that women seem to have a higher rate of depression. It's unclear why this is. There are many hypotheses about it. If you look at the rate of depression in boys and girls through childhood, the separation starts to occur around puberty, when girls and then women have a higher rate of depression. That's led some people to think that there may be some endocrine reason. Others have given sociological explanations. The stress on young women is different than the stress on young men. There's one interesting study that didn't find a gender difference, and that was in a population that has no substance abuse, the Amish. And because if you abuse substances in the Amish community, you are no longer in the community. So in that study, they found the rates of depression equal between men and women. There's some hypotheses that in the men, the depression is being masked by substance abuse. And our chair, Dr. Zadonis, has done a lot of work about the comorbidity of substance abuse and mood disorders, which is very, very common condition. Now, just to dispel some misconceptions about depression, depression is not a treatable disease. That is not true. I mean, every week I have at least one person come into my office and say to me, my depression is not treatable. No one's ever been able to treat it, and you won't be able to treat it. But of course, I tell them that I've never seen a person in the 25 years or so I've been doing this that I couldn't help in some way. Depression is a weakness of character. It's a more New England phenomenon. I was not originally from here, and when I came up here, I started hearing this, that I'm weak, and people who are depressed feeling that way. Although, the depressive illness, as Dr. Brown mentioned, can color one's outlook of the world, and so that one begins to think that one is weak. And then another misconception is that antidepressant medications cause dependence. They do not. That's it. Just to say that would be the equivalent of saying a diabetic is dependent on insulin, or that insulin causes dependence. I mean, a diabetic needs insulin. And if a diabetic doesn't get their insulin, they're going to get sick and they're going to get in trouble. Same thing with antidepressants and depression. I mean, people who suffer from depression need to take their antidepressant medicine and have a high risk of relapse if they don't take it. But it doesn't mean that antidepressant medications cause dependence. Now, major depression is not the same thing as being depressed over a life event. Feeling depressed over things that happen is a normal part of living. And as I'll show you in a moment, if all you have is a sad mood, if all you have is feeling depressed or sad, that's not enough to make criteria for major depression. Major depression is a total body illness with a lot of symptoms in addition to the sad mood, and I'll show you that in a moment. I already told you depression is treatable. The American Psychiatric Association guidelines for the treatment of depression recommend that for moderate to severe depression, antidepressants should be used. For milder forms of depression, psychotherapy might be the only treatment, and no medications may be used. I've always come from the school of thought that believes, and there's certainly studies to back this up, that in the ideal world, a person suffering from depression, whether mild or severe, would get both medications and psychotherapy because they work on different aspects of the disorder. One thing I thought might be interesting just to use as an example, that the difference between major depression and a grief reaction. So that if somebody close to you passes away, a person can develop all the symptoms of what looks like major depressions: feeling sad, having crying spells, having trouble sleeping, losing interest in doing one's usual activities, losing one's appetite, losing weight. And one does not want to treat a grief reaction, which is a normal part of living, with, for example, antidepressants. First of all, they wouldn't work, and second of all, it's missing the point of what is a normal reaction to the loss of a loved one. But once in a while, a grief reaction can progress over time to a major depression, and that can be a very complicated situation to figure out. But one thing I would mention is that people who have a grief reaction, certainly in our culture in the United States, I mean, usually after a couple of weeks, a person is back at work and functioning, and going to the grocery store or going to school on average. Whereas somebody who's suffering from major depression often has difficulty with those types of things and is not functioning. That would be a situation where a family might want to have someone evaluated if somebody is having trouble functioning, even in the context of it may have started with a grief reaction. And then also suicidal thinking. Suicidal thinking is usually not seen in somebody who has a grief reaction. It's a common feeling in people who suffer from major depression. And whenever that occurs, it's always important to have someone have an evaluation. So the common presenting symptoms for major depression, I'll go through in a little more detail what they are, but they're things like fatigue, chronic aches and pains, trouble sleeping. Trouble sleeping is very common. 80% of people who develop major depressive disorder start with a sleeping problem, and it can be trouble falling asleep, taking more than an hour to fall asleep, trouble staying asleep, so a person falls asleep but then constantly wakes up through the night, and then something that you almost see in nothing else but depression, something called early morning awakening. That's when a person wakes up at 3 or 4 in the morning and can't get back to sleep at all. Now, if it happens one time, I wouldn't make anything of it. But if it happens a couple of times a week, that is often a sign that someone is suffering from major depression or may develop major depression. Anxiety is very common in major depressive disorder. Irritable mood is very common, and GI disturbances. Now, there are risk factors for developing an episode of major depression, and it can happen at any age to anyone. People have looked at this. I mean, it can happen, you can happen at any decade of life. The average age is 40, but half the people are over 40, half the people are under 40. It's not related to any socioeconomic status. There have been these populations that have had some people thought it was due to Western culture, but these populations that have had little exposure to Western civilization. There was a tribe of Eskimos. There were some Aborigines in the Philippines. They also had people who had suffered from this disorder, and actually, as I'm sure you may know, there are descriptions of this in the Bible. But there are some risk factors. Having had depression before, a family history of depression, and that would be a first-degree relative, a mother, father, brother, sister, child. Lack of social supports is a risk factor. Stressful life events do play a role, particularly loss of a relationship, loss of a job. Substance abuse is a risk factor, and medical problems are a risk factor for depression. So here are the criteria. I just want to go through. This is actually what a psychiatrist or any doctor would use to make the diagnosis of major depression. And I want to make a few points about this. In order for the diagnosis to be made, a person has to have either depressed mood or anhedonia, which means loss of the capacity to experience pleasure, plus a number of other symptoms, which I'll go through in a moment. One point I want to make is you don't have to be sad to make criteria for major depression. You can have anhedonia, loss of the capacity to experience pleasure. So, for example, I'll ask somebody, what do you do for fun? Now, of course, if they look at me like I don't understand, I can tell there's nothing right now that they're doing for fun. So I might ask them, well, what did you used to do for fun? And they might say, I used to like to golf, or I used to like to go swimming, or I used to like to read books, and then they'll tell me they don't do it anymore because they don't derive any pleasure from it. That's anhedonia. So someone has to have either the sad mood or anhedonia, plus a number of other symptoms, at least 4 more symptoms: sleep disturbance, loss of appetite or weight loss, psychomotor agitation or retardation, feelings of fatigue, decreased concentration or thinking and indecisiveness, negative thinking, worthlessness or inappropriate guilt, and recurrent thoughts of death or suicide. Now, just one point about this. This is actually very common, although the most common thing is people will say to me, I don't really care, doctor, if I die in my sleep, or I wouldn't care if I, got diagnosed with a serious illness. It's that kind of feeling, not necessarily that somebody would have a plan to harm themselves, but that people just don't care. That not caring is very common. Just very quickly, because I only have about 4 or 5 minutes left, there are a lot of theories as to what the causes of depression. There's a lot of research going on. It's very complicated. Depression, like most medical illnesses, is an interplay between the person's biology and stresses that occur in people's lives. Just the picture shows one example. Stress has effects on the body. It has effects on one hormone system called the hypothalamic pituitary adrenal axis, which is in the starts in the hypothalamus, which is kind of the conductor of the orchestra, so the conductor of the brain. Corticotropin releasing factor is part neurotransmitter in the brain and part hormonal message to tell the pituitary to make a hormone that tells the adrenal gland to make cortisol. And in depression, this axis, this hormonal axis, is out of whack. It's actually hyperactive. And as I'm sure you may have heard about, there are biochemical changes, mainly in the serotonin and norepinephrine system. And as you'll hear more from Dr. Deligianidis, that this is how some of the medications work. I think I'll skip some of this, but there's a lot of animal data and animal models of depression, as well as human data, that shows that norepinephrine and serotonin play a role in this. But it's not clear whether this is the original cause of the depression or this is a result of something else, like stress, for example. But from a practical standpoint, this is how our medications work, and our medications do work and have been shown in scientific studies. Freud, he's a little out of favor these days, but he was onto something in terms of loss and that resulting in depression. Cognitive therapists work on, very often people with depression develop, for lack of a better word, bad habits. They'll think of a situation, and every situation they can think of, before it actually happens, they'll what's called catastrophize, and they'll have a terrible ending to whatever, like if they have a job interview, they sort of run through what all the bad things that will happen and develop a pattern of thinking. And cognitive behavioral therapy works on teaching people to change that level of thinking. And just as my last slide, I just want to make the point that this is a medical disease. So this is whatever the cause is, and the exact cause, like many medical illnesses, is not precisely known. But if you do a PET scan of somebody who is suffering from depression, there are areas in the frontal lobe that are just not that active compared to somebody, this is actually the same person, who has recovered from depression. These red and green and yellow areas are more in the frontal lobes are more active. There are other areas of the brain not shown on the slide in depression that are hyperactive, and in the recovered person have toned down. And these are circuits in the brain that change when somebody is depressed and when they are no longer depressed. So in summary then, and I'll be around later for questions, depression is common. Depression is a medical illness. Unfortunately, if untreated, besides causing a lot of pain and suffering in a person's life, can sometimes unfortunately be fatal. But the good news is depression is treatable. And there really is not necessary for anyone in 2011 to suffer through life with untreated depression, as some people do. I mean, there's some very successful people who despite their success, have suffered from depression, and it's not necessary for people to suffer from depression in this day and age. Thank you very much.
Thank you, Tony. Our next speaker is Dr. Christina Deligiannidis, who is Assistant Professor of Psychiatry and Medical Director of the Depression Specialty Clinic here at UMass Medical School in the Department of Psychiatry. She received her medical degree from UMass Medical School and completed her psychiatry residency and chief residency in psychopharmacology research here at UMass Medical School. I guess she likes this place. Still here. She additionally completed research training at the National Institute of Mental Health and the National Institute of Child Health and Human Development. She joined the UMass faculty and its clinical partner, UMass Memorial Medical Center, in October 2009. She is the medical director of the Depression Specialty Clinic, as well as providing consultations and short-term treatment for women suffering from depression during pregnancy or postpartum period at the Women's Mental Health Specialty Clinic here at UMass. Dr. Deligiannidis' research efforts have been nationally recognized, and she has been and continues to be a recipient of many national awards in psychiatry and psychopharmacology. She is also a member of numerous associations and societies, and we'll talk about different treatments for depression. Welcome.
That's okay. Do you want to end and then?
I gotta hit this one, and then this one's. I think it's this one.
I think it's the other one.
Oops. There you go.
Good evening. Good evening. I'm Dr. Christina Deligiannidis, and as Laura said, I'm Assistant Professor of Psychiatry here at UMass. And I do love it here. I can't seem to leave. And I'm delighted to be invited tonight to speak to you on treatments of depression. Also, welcome Barry Family Health Center. Delighted to have you here. And everyone here in the audience, and anyone also viewing the program through our television coverage this evening too. I'm going to start the evening with, as well, my disclosures. I do receive research funding from the UMass Center for Clinical Research and the Worcester Foundation. And those are to fund studies in perinatal depression. So I do have a specialty focus in depression in women, especially in pregnancy and the postpartum. And then also from Forest Research, I'm investigating a depression study as well. I do have royalties from an antibody that I developed when I was at the National Institutes of Health. And so I put that up there as well. Oh, that's working better. So this presentation is going to include both treatment information on US FDA approved medications and FDA cleared if it's a medical device, and also non-FDA approved treatments for depression will also be discussed. But that's only going to be one slide on complementary and alternative medications, and I'll indicate that as such so it's clear. My overview of the presentation that I will give tonight is that I wanted to start with what a clinical evaluation for depression entails, because it's that assessment that guides our personalized treatment for depression. Then I'm going to take you through general treatment considerations, and then we'll walk through many modalities of depression treatment, ending with future treatments currently under research. So the assessment for depression is critically important because, as I said, it is the guide to personalized medicine, to personalized treatment for depression. We want to know all of the signs and symptoms that Dr. Rothschild had reviewed in his presentation. We want to know about past episodes, past hospitalizations, if a person's had a history of suicide attempt, if there's been a history or current substance abuse, have those been linked to the mood episodes? What have those treatments been like and how successful have they been? We absolutely must consider all medical conditions, past and current, treated and untreated, to understand the interplay between medical conditions and depression and vice versa. We also ask questions about psychological development, life transitions, history of abuse or trauma, interpersonal functioning. There are so many aspects of the human being that's so critical to understand why a particular person has depression and why they have it now. We want to know, because of some of the genetic factors that were reviewed, about family history. If members in the family have had depression, have they been treated? What medications were helpful? What treatments were effective in those blood relatives? And then we want to review any other psychiatric, neurological symptoms a patient may have, and then complete our full psychiatric evaluation, neurological exam, and risk assessment, because thoughts of death or not wanting to live are so common with the disorder. So that gives us really a good understanding of how we can personalize treatment. I'm actually going to back up and talk about general treatments for depression. We want to promote healthy living with exercise. There's research on aerobic exercise in particular, and also resistance training. Good sleep practices. Sleep is often disturbed in depression. Good nutrition. Strategies in decreasing the use of tobacco, alcohol, and other substances that not only have ill health effects, but also can counteract depression treatment. And then treatment of any medical conditions that can impact the symptoms or the treatment of depression. Again, other considerations are that education about the treatment. So not just the treatment itself, but educating about the treatment is so important. When and how to take the medication, what side effects are common, what do I expect, how to manage the side effects if they occur, the need to take medication even after feeling better. And there's going to be a slide that's going to come up 1 or 2 slides from now. We'll go into a little bit more detail on that. How to discuss with your physician about stopping medications, because abrupt discontinuation of some medications is a real risk for relapse and can have side effects as well. If a patient is engaged in psychotherapy, how do those talk therapies work? How to maximize their benefit? I think of talk therapy as a medication that can be titrated. It has a dose. Are you seeing someone weekly? Are you working in a group? Are you seeing someone on a monthly basis? Is it the right frequency, the right strength? Are there side effects? It's a treatment. And all of those things should be educated about and be very clear. And then what are the goals? So our goal is to have complete recovery, not just improvement. It shouldn't be, well, you're 50% better, so that's pretty good, right? You feel better, better-ish is better than you were before. That's not good enough. Our standard is complete recovery, and what we call that is remission. Recovery and remission, it's complete resolution of symptoms. The person is at baseline functioning. Often we first see a response. So we see improvement first, and then we see remission. One thing that's so important to know about depression is that recurrence is often, and I bring this up because it's critical for any treatment discussion, is that if a person's had one episode of major depression, 50% chance that that person will have another one in their lifetime. Now they've had 2 episodes. Now it's a 70% chance that they're going to have an additional episode. If you've had 3 of your lifetime, 90% chance. You see where I'm going with this. So the more often you've had an episode of depression, it predicts that this is indeed going to happen again. And that really does guide how we personalize a treatment plan for a person, because that's really important information of knowing how long to treat. So I use this slide because I like pictures and I had no pictures until now. So this goes into a little bit about phases. This has a pointer, right? Yes. So up here it's euthymia. That's the good mood state. So we want to be here. When a person has an episode of depression, the symptoms bring them down here. And then this is where we start treatment. So we start a treatment, whether it be medication therapy, and I'm going to walk you through the different modalities. And we start to have a response. And so that's great, but we want to keep moving up this curve. Because of those numbers that I just told you, we can see relapse at any point on this curve, either as the person's getting better, or if they've remitted, they are still at risk for relapse at any time, or recurrence if it's further enough out. So we keep this in mind, and that kind of highlights the reason of it can be dangerous to stop a medication when you start to feel well. And it pains me when I hear of some patients who have not had the education and have taken their medication almost as needed. Well, I had a blue day, and so I took my sertraline, or I took it for a couple weeks, and they really were feeling great, and then stopped it, and then had a severe recurrence. So now I'm going to go through the major modalities of treatment. There are more treatments than I can even cover in 20 minutes. So I'm going to speak in very broad strokes and start with antidepressant medications. For most patients, the newer antidepressant medications are the first line of treatment, and these are in about 3 categories: the SSRIs, the serotonin reuptake inhibitors, and the serotonin norepinephrine reuptake inhibitors, the SNRIs. And they kind of tell you what system of neurochemistry they're based on, where they're focused. Then there are other medications that additionally can work on these systems, but have other functions as well, and they're kind of in an other category. These medications are effective, and they're generally well tolerated, but with any prescription that I write or that anyone else writes, or any over-the-counter medication, or if it's an herb, there can be side effects. And so we really have to understand the risks, the potential side effects of a treatment, the benefits, and then if the alternatives to treatment too. Major side effects of the more common ones in these classes can include sedation, weight gain, headache, nausea, and sexual dysfunction, both in men and women. There are older classes of antidepressants. They're very effective as well, but the way I see them is that they have a different side effect profile than the newer medications. And some of these medications are are better for certain subtypes of depression, which we didn't have time to go into this evening. These fall into the tricyclics and the monoamine oxidase inhibitors. And whenever we prescribe from the monoamine oxidase inhibitor class, which is an older medication class, we also prescribe a diet. So this is one of those medications in medicine that we also prescribe a diet to prevent side effects. And for here, a low tyramine diet is necessary to prevent severe high blood pressure as a side effect. The side effects of these classes of medications can differ, but again, speaking in broad strokes, they can include low blood pressure, constipation, dry mouth, urinary hesitancy, which is a difficulty initiating or emptying your bladder, vision changes, sexual dysfunction, again for men and women, sweating, sedation, or weight gain. Now, transitioning from medication treatment of depression, we're going to speak a little bit about a category which we call neuromodulation or brain modulation. This is probably one of the more common modalities. It's been around the longest, electroconvulsive therapy. And this is a medical device cleared by the FDA, and it's the most effective form of antidepressant treatment, but it's not the most common. 70 to 90% of patients experience improvement, and numbers are different for different disorders that also use electroconvulsive treatment. Treatment are given 2 to 3 times per week over a couple week periods for that acute phase of depression treatment. It's safe, and the major risk that's involved with ECT is that of anesthesia. So general anesthesia is required for the treatment. The treatment involves passing an electrical current through the brain to induce a seizure. And the side effects, again, can be due to the anesthesia, but also confusion, memory loss, and some blood pressure changes, which can be common during the treatment. There is a recovery phase after the treatments. A newer neuromodulation treatment includes transcranial magnetic stimulation, or TMS, and this was more recently cleared in 2008 for patients who have major depression for whom an antidepressant didn't get them back up to that baseline. So they started to improve and then stalled. They couldn't get all the way better. They did not remit. And this procedure, these cartoons are from the National Institutes of Health. And so if you want more information, there's wonderful guides there. But I'm not responsible for the cartoons. Actually, you don't sleep through this procedure. You'd have your eyes open and you sit in something that looks like a dentist chair while this happens and you're awake. But the procedure uses a magnetic field to produce electrical stimulation of neurons or brain cells in areas of the brain implicated in depression. And they focus it right over the front here. And the treatment involves daily 1-hour sessions over a couple of weeks. Again, there's no sedation or anesthesia required. And the main side effects that have been reported are headache and scalp discomfort. Now, for patients whose depression has not responded to at least 4 antidepressant medication trials, and these are at adequate doses over an adequate period of time, and or ECT, there is a device that has been cleared by the FDA that is also used in epilepsy, is the vagus nerve stimulator, or VNS. And it's used for small long-term treatment benefits, and often in conjunction with continued antidepressant medication and or psychotherapy. It's not used for that acute depression treatment, that first part of the slope that we looked at. It does require a surgical device implantation into the left chest wall. It's very similar to surgery that you'd have for a pacemaker insertion. But there's a coil that's wrapped around, this might be too low to see. I should put it. So the pacemaker is here in the left chest wall, and then there is a wire that is run up here and is wrapped around the vagus nerve. Now, you say, like, why this nerve and not any other? Well, this is the way into the brain without going into the skull. So the vagus nerve is our access to the brain circuits that we want to change in depression. Now, side effects of this procedure and treatment include the risks of post-surgical infection, so surgery after the incision, voice changes, cough, and those are because this nerve and the surgery is very close to the voice box and the nerves around the voice box, and also neck discomfort or pain. Leaving now brain modulation or neuromodulation, I wanted to talk about talk therapy. And again, all of these treatments target different aspects of depression. Psychotherapy is particularly helpful in addressing the psychosocial stressors or the psychological factors that can either impact the development of depression or that keeps it going. And it's often, again, combined with medication treatment. And I believe, as a practitioner, in all stages, mild, moderate, or severe. There are many kinds of talk therapy, and they target many different aspects of depression. I could only list a couple without making the font really small. So negative thinking style, interpersonal difficulties, social isolation, role transition problems. There are individual therapy models. There are group talk therapy models. There are couples and family therapy models as well. So this is a very adaptable modality that focuses on, in a very personalized way, exactly what's happening in that person's life. I did want to talk about complementary and alternative treatments, although briefly. The National Institutes of Health define this group of treatments in the following: as a group of diverse medical and healthcare systems, practices, and products that are not considered to be part of conventional medicine. This is that slide. So none of these treatments listed here are approved by, nor are they monitored by, the Food and Drug Administration. So things like medication strength, medication purity, the presence of impurities, those things that are monitored, and also efficacy trials, are not monitored by an outside agency. And so what I did was I listed the ones that have the most research evidence in depression, mostly mild depression or minor depression, but those include St. John's wort, SAMe, as it's commonly known, S-adenosylmethionine, and SAMe is actually a naturally occurring molecule in the body. And then the omega-3 fatty acids, which are your fish oils, and used for other conditions too, especially in heart conditions. Those are typically as adjunctive therapy to antidepressants. And then there are studies that have looked at folate, bright light therapy, and also acupuncture. So where do we go from here? Because some patients continue to have symptoms or recurrences that don't respond to some of the treatments that I've given you a global view of. What's exciting to me is that we're now at the point where we are investigating new transmitter systems, new neurochemicals. We are understanding the pathophysiology of depression in a whole new way, looking at the interaction of many different systems interacting together, looking at neurological circuits of depression and how do we modulate them. And so I believe our therapies are becoming more and more specific. We are looking at, when you looked at the names in the classes, you kept seeing serotonin and norepinephrine, and sometimes you'll see dopamine. If you're lucky, you may see GABA, but we don't have medications to all of those things. These new targets, you may not have heard of, because these are these new targets that are under development now. Those include the glutamate system, the neurokinin receptor, the nicotine receptor, antiglucocorticoids. That goes back to the stress and the CRH response. There are new talk therapies coming. And then in that neuromodulation area, the brain modulation, there's now research into deep brain stimulation. And these have come out of studies that have looked at this procedure in other illnesses, things like Parkinson's disease, obsessive compulsive disorder. And this involves surgical implantation of an electrode into the area, into the circuit of depression to induce electrical impulses to change how that circuit functions. So we are, I am part of a center for psychopharmacologic research and treatment, and I couldn't help but to say that our team conducts medical research, and our director is Dr. Rothschild. We are investigating these new treatments for major depression. So if anyone is interested in taking part in a depression study or just wants to learn more, I'd highly recommend that you give us a call. We would love to speak with you. And that's the end of my presentation. Thank you.
If I can get this right. Our next speaker is Dr. Gary Moak. Dr. Moak is Clinical Associate Professor of Psychiatry at the University of Massachusetts Medical School and Director of the Moak Center for Healthy Aging, a geriatric psychiatry group practice in Westborough, Mass. He completed his residency in psychiatry and fellowship in geriatric psychiatry at the University of Pittsburgh, and he is the past president of the American Association of Geriatric Psychiatry. Welcome, Dr. Moak.
All right, can everybody hear me okay? All right, great. Perfect. So I think we've heard some wonderfully fantastic information about depression, which in the remaining talk this evening, I hope to build upon in terms of focusing on older patients with depression, in particular, what's different about depression among older people. And I'm going to approach this from two particular perspectives. So we're going to talk about, we're going to focus on a subgroup of people with what is referred to as late life depression. Among people with geriatric depression, people with older people who have depression, there are those who have had depression since they were younger and who have grown old with it. But by and large, the larger group of older people with depression, who in some ways present a bigger problem for the healthcare system and a bigger level of disability and suffering for themselves and their families, are people with late life depression, people who have enjoyed good mental health their entire lives and for the first time in old age have a mental health problem and become depressed. And we're going to focus on why it's critically important for people with late life depression. And by the way, what my remarks about late life depression by and large apply to other people with depression as well, but as you'll see, late life depression is a little unique. But what's critically important about we'll talk about what's so important about getting it treated, making sure that's treated effectively. As Dr. Rothschild already mentioned, there are a lot of people who live with depression chronically, suffer in silence, and somehow muddle through. And that problem may be greater for older people, particularly older Americans, but that tendency cuts across most cultures and most ethnic groups. And for these people, the consequences of living with chronic depression are greater. And the importance of getting treated is greater, and that's something I want you to take away from this talk. So depression in the elderly is a very common problem. Dr. Rothschild gave us a good understanding of how psychiatrists think about a particular illness called major depression. And what sometimes confuses many people is studies that show the rate of major depression is actually lower among older people. But geriatric specialists like myself think about depression differently, and we treat a group of people with clinically significant depression who might not meet the criteria to say they have major depression, but they have a type of clinical depression that's very significant, puts their health at risk, and is quite disabling. And that accounts for about 1 in 5 people over the age of 65. So this is a huge problem, and as you can appreciate, as the number of older people is rapidly increasing, actually at an alarming rate, depression among these folks is going to be a bigger and bigger problem that we're going to be forced to deal with one way or another. Now, one of the important differences, and we've heard some discussion already about how we think about what causes depression and how our thinking about that has changed from the days of the Freudian model to more modern brain science-based thinking. But in geriatrics, we think about late life depression differently than we think about depression in younger people. And we think that it may be a similar condition with overlapping symptoms, but in fact may represent a different disease process with a common outcome. And that's what I'm going to try to help you appreciate better. Now, Dr. Rothschild also mentioned the fact that there are many biases and myths about how people think about depression, and that certainly is true among older people and their families, but actually it affects healthcare workers as well. Home healthcare workers, hospital staff, long-term care facility staff, and actually many primary care doctors, neurologists, and even some psychiatrists, I regret to say. So we hear commonly assumptions that people make, such as that old age itself is depressing, so why would it be surprising that old people have more depression? Depression is an expectable outcome of getting older. Depression is part of the aging process. And most malignantly, nothing can be done about it. And these are all false, and it's critical, if you take nothing away from this talk, to understand that none of these assumptions is true. Depression is not a normal part of the aging process, and it's not an expectable reaction to getting older. It's not uncommon in the kind of work I do to come across somebody who's had a stroke or has become disabled after a hip fracture and has become quite depressed, and that's evaluated for one reason or another, and they and their family members are kind of taken aback by the idea that somebody thinks they might have depression, with the rationalization, well, what do you expect? If you had a stroke or broke your hip, why wouldn't you be depressed? As if somehow the idea that they have depression is an accusation that they're in some way weak and not handling the situation effectively. This is a very destructive way of thinking that needs to be addressed very actively. Now, late life depression, even depressions that are not major depressions, represent a very serious public health problem, as I already said. Depression is a major factor in poor quality of life, and it may be the #1 threat to quality of life in old age. So in terms of good results and aging well, preventing and treating depression may be the most important thing we can all do to improve the well-being of older people. It's a huge burden on family members. So increasingly our culture is aware of the caregiver burden families experience caring for Alzheimer's disease patients. But studies show that if you're taking care of an older relative with depression, the stress and strain you're under and the burden you experience related to that is much greater than what you experience taking care of somebody with Alzheimer's disease. And so we really need to think about that and consider late life depression to be a family illness. It affects everybody who's involved in the life of that older person. Depression is a factor in suicide, and more than is the case in younger people, depression is more likely to be associated with suicide in older people. Older people who decide they're going to commit suicide are better at it. They're more lethal and they succeed more of the time. And depression is a huge source of preventable, treatable disability. And the World Health Organization recently has classified depression as the leading cause of disability worldwide. That's staggering to think about if you do for a minute. Very few people appreciate that. Unfortunately, most older people with depression fail to receive treatment for it. There are a lot of reasons for that. Can't really get into all of them this evening, but a big part of it is the reluctance people of this age cohort, people that are currently older, reluctance they feel in terms of recognizing and admitting they have a mental health problem and seeking treatment for it. So older people often will not go to a mental health care service, but even when their primary care physicians identify the problem and are interested and willing to treat it and offer treatment right in the primary care setting, many older patients still remain very reluctant to treat it. That has to be addressed. Again, part of the problem, and it's complicated, but part of the problem is there's a tendency they have to feel stigmatized by a mental health problem, to feel they're somehow weak, that they failed as people, and they assume that there's nothing that can be done about it, that it's something you just have to live with. And actually, in many cases, because of that, they may not report symptoms. They may keep those symptoms to themselves and not disclose what's going on, even to their closest relatives. The result is that depression among older people is more likely to be chronic, and that has its consequences. Few people appreciate that chronic depression takes a huge toll on physical health. So depression is not only a threat to mental health, but it's a threat to physical health, and that affects patients of all ages, but is even greater in old age when people are frail and bodily reserve capacity is down and their vulnerability to all kinds of illness and disability is greater. So many studies, too numerous to count and cite, show very clearly that depression in old age is associated with a greater rate of physical sickness in general, more visits to the doctor, more visits to specialists, more use of medicines, greater use of healthcare services like trips to the emergency room, hospitalizations, and the like, and getting all kinds of tests for various kinds of problems that don't lead to a specific diagnosis. Very tragically, depression in old age can be a cause of avoidable admission to long-term care, and it's not uncommon for me in my practice regularly to see people who wind up in an assisted living facility or a nursing home because of a serious depression that wasn't treated, that had it been treated a year or two earlier, they'd still be living at home with their families or if they're in their own home on their own. It's really a shame when someone winds up in a nursing home because of depression that could have been treated. And most frightening is that untreated depression in older people is associated with a higher death rate. Oops, didn't want to do that. There we go. That wasn't too hard. Now, late life depression is more difficult to recognize and diagnose often than depression is in younger people. Part of it is that because the illness, major depression, may look different in old age than it does in younger people. We may have to change the way we diagnose depression in older people, but also because there are other kinds of clinically significant depressions that may be as severe and disabling as major depression, but may not be the same disease as major depression. A couple of differences that I want to highlight is that older people who are depressed are less often sad, gloomy, down in the dumps, or tearful than younger people are. They certainly can be that way, but they're less likely to have those as the prominent symptoms. They're much more likely to have anxiety as the more prominent symptom, and that often leads to treatment with medications for anxiety, failure to diagnose the depression, and failure to treat the correct diagnosis. And on the opposite side, rather than having a lot of anxiety, they may actually have more apathy. They may have something called executive cognitive impairment, which is different from the kind of typical cognitive impairment we look for in older people that may be developing early signs of Alzheimer's disease, where memory is the primary symptom. And because their memory may not be too bad, it may mislead many people to not appreciate why they're just not thinking clearly or functioning well. Older people with depression often can be angry, irritable, or agitated, and often very negative. And the negativity may cause them to refuse to get up and get out of bed. So they may lay in bed for days at a time, become very deconditioned, weak, unable to walk. If they're in a rehab setting, they may refuse physical therapy and occupational therapy needed to get them better and get them home. They may refuse to go out of the house. They may refuse to eat, drink, or even take their medicines. And these things in older people who are very frail can present life-threatening emergencies. They may have more in the way of obsessive and compulsive behaviors, and oftentimes this overlaps with lots of excessive worries about physical symptoms and physical health problems, particularly things like bowel functioning, bladder functioning, sleep symptoms. So these people often are going from doctor to doctor looking for a better sleeping pill. Sometimes they get the sleeping pill, which then causes other problems that we have to deal with. But they get all kinds of gastrointestinal treatments and tests. They get bladder therapies, and all kinds of things happen because they're very focused on physical problems and worrying excessively about that. Now, the other problem in old age is that many of the symptoms that we look for to identify depression in younger people are nonspecific in older people. So symptoms such as loss of interest, poor motivation, social isolation, poor appetite, sleep disturbances, mental sluggishness, and a whole host of other common symptoms all can be symptoms of depression and commonly are identified as such. But the problem is they can be symptoms of dozens of other health conditions: arthritis, thyroid conditions, heart failure, chronic lung diseases, Alzheimer's disease, congestive heart failure, Parkinson's disease, and even reactions to medicines that people are receiving for those conditions. And the fact that these symptoms can be attributed to these physical problems, or the treatments for these physical problems, often goes unrecognized. And that becomes an important part of the evaluation of older people with depressive symptoms. Now, a critical difference is that, as we've already heard, there is a physiology to depression in younger people and even a familial transmission to it. One of the differences in old age is that late life depression may be more associated with cerebrovascular disease and other physical health problems than it is in younger people, and it's less likely to be associated with a family history of depression and family transmission. As I said before, it's more likely to be a factor in suicide than it is in younger people, and it's more likely to be recurrent, chronic, and brittle. So older people who are depressed, the depression may last longer, be a little bit more resistant to treatment, which means it requires a little bit more work to get them better. It's more likely to relapse, and it's more likely to relapse easily, so that it may involve a lot of work with a fairly intensive maintenance treatment to keep people who are depressed, who get better, from getting depressed again. They're very vulnerable to frequent relapses and require a lot of active treatment to keep the depression under control. This slide just gives you an idea of the impact of age on the suicide rate. And it's important for people to understand that older men have 5 times, men over the age of 85, have 5 times the rate of suicide the rest of the population does. It's a huge, huge problem, particularly for men more so than women. But you see this striking increase in the suicide rate with the aging of the population. And a more chilling statistic is that while many older people don't go to see psychiatrists or mental health specialists, almost all of them see primary care physicians. And many studies show that 70% of older people who committed suicide actually saw their primary care physician within a month of killing themselves. Even more alarming is that 40% were there that week and 20% were there that day, were in the primary care doctor's office, went home and killed themselves. So we're missing an opportunity to pick this up and do something about it, and that needs to be addressed. So as I said earlier, one of the things we view differently about late life depression is we see it as a manifestation of brain disease. Cerebrovascular disease, meaning overt strokes that we know people have had, dementias like Alzheimer's disease and other kinds of dementias, illnesses like Parkinson's disease, but also illnesses like multiple sclerosis, other kinds of brain diseases that commonly are seen in older people. But we also believe that it's a manifestation of small vessel cerebrovascular disease, a type of insidious, slowly progressive narrowing of the very, very tiny blood vessels that feed the deeper centers of the brain, where some of the circuits lie that Dr. Rothschild referred to earlier in his talk. And that these manifestations don't occur usually with a discrete stroke or a discrete neurologic event. They come on in an unrecognized, insidious way. And this type of depression, researchers have, think is a valid model of looking at depression, at the cause of depression in old age, so much so that the coin vascular depression has been coined to describe it. Many of you may know that one cause of late life dementia, one of the the second or third most common causes after Alzheimer's disease is an illness called vascular dementia. We also now talk about vascular depression. And we think, again, it's because the cerebrovascular disease may affect the circuits deep in the brain. Now, what is missing here, and I wish I had a way to figure out how to bring this up, is I had 4 slides showing you MRI scans of otherwise neurologically healthy older people with vascular depression to show you the kinds of changes deep in the brain that we can see on MRI scans that are associated with depression. And it would be nice if we could see it, but it's not the end of the world. And this next slide, unfortunately, shows pictures using a newer imaging technique called DTI, which actually gives us very nice pictures of the fiber pathways in the deep white matter of the brain that actually are the pathways that make up some of these circuits that we've been talking about. So what we can see is that in areas where there is cerebrovascular damage to parts of the brain, we can actually see the pathways making up these critical brain circuits that are affected. And it's led us to really view late life depression as a circulatory problem in the brain. It's a physical neurologic disease whose main manifestation, at least initially in old age, is a depression type condition. Now, this also causes something that is a little bit more characteristic of late life depression, which is called the depression executive dysfunction syndrome. And this occurs because the impairment in the circuits deep in the center of the brain impair connections between deep areas in the brain and the frontal lobes, which are the executive command centers of the brain. So what you often see in older people who are depressed is that they may exhibit poor planning and organization of their lives. They seem to fall apart and become dilapidated. They seem unable to function. They're unaware that they need to do things, keep appointments, take medicines, take care of themselves, eat properly. It can be a huge problem for somebody with diabetes who has to follow a diabetic diet, or somebody with chronic renal disease who has to follow a renal disease diet and take medicines carefully. They often seem to have poor attention span. They have impaired working memory, very impaired difficulty with reasoning and making good decisions, and they seem to have little motivation. People have a hard time understanding and recognizing this for what it is. It's actually a type of dementia, different than the dementia we see in Alzheimer's disease, but it often leads to caregivers becoming very frustrated because the common sense conclusion is the person's kind of helpless, they're looking for attention, they're doing it on purpose because they seem to know how to do things, they just don't do it. Whereas most people know someone with Alzheimer's disease who wants to do it but just doesn't know how to do it anymore. So it's hard to understand why this person isn't doing what they're supposed to do, and it's maddeningly frustrating. And that can be a big part of why this is so much more stressful for family members. Now, as I said earlier, chronic depression negatively impacts physical health, and older people are much more frail to these effects. So without spending a lot of time discussing how this occurs, as Dr. Rothschild already mentioned, chronic depression creates a physiologic state in the body that's kind of akin to chronic stress. And this is very detrimental to health, and it's actually very detrimental to the brain. But in people who are depressed, who have illnesses like heart disease, cancer, diabetes, chronic lung disease, arthritis, Parkinson's disease, if they also have depression concurrently, the symptoms of these disorders are worse, the disability associated with these disorders is worse, and their outcome is much worse. It leads to such things as a much higher death rate after a heart attack. So if you have a heart attack and you're depressed, your chances of dying within the next year are 4 times greater than if you're not depressed. Depression is now clearly seems to be a risk factor for having a stroke. So if you're older and you have chronic depression, your chance of getting a stroke, having one, is higher. And if you have a stroke and you become depressed or have been depressed and are still depressed, your outcome after the stroke is less favorable. You're not likely to not recover as well and not recover as quickly. You're likely to have more cognitive impairment and become more permanently disabled because of the stroke. So it's one of the things that's critical in treating people in terms of stroke rehabilitation is recognizing when they're depressed and doing everything possible to treat that. And if you have chronic kidney disease and you're depressed, your chances of ending up on dialysis are much higher. So this is not something that you can just live with without consequence. If you're depressed, it's going to take a huge toll on your health. We also think that depression can lead to a kind of dementia syndrome in two ways. In the short run, depression turns off certain brain functions that are needed for cognitive processing. So people, when they're acutely depressed, at least older people, don't think clearly and seem cognitively impaired and may look as if they're demented. Over the longer run, chronic depression, possibly because of the impact of stress hormones that are running wild on the brain, may lead to shrinkage of critical memory centers called the hippocampus. And the shrinkage can actually resemble in severity what's seen in moderate to severe Alzheimer's disease, which is scary to see when you see it, and also can lead to a reduction in healthy brain cell connections in other critical parts of the brain. And these kinds of effects may not be repairable when the depression is treated. So, many people will resist getting depression. If you tell them, if you knew you were going to get Alzheimer's disease and there was a treatment that would prevent it, would you take it? They would clamor to take it. But if you have a treatment for depression, they may not take it, not appreciating that depression itself can lead to many permanent brain symptoms that overlap the symptoms of Alzheimer's disease. Now, as I said, treatment can be more difficult, but it still works. Old people respond to treatment as well as young people do, but it may take more work. It may take longer, and it's more complicated. It's more complicated for a couple reasons. One is that people have lots of other illnesses. So in thinking about treating depression, you have to take into consideration the whole host of other illnesses people have and the other medicines they take and deal with those interactions. And you also have to compensate for people's functional impairment and cognitive impairment and the fact that their social supports may not be as strong as they used to be. I mentioned that depression is a bit more brittle than it is in younger people, and good studies show that maintenance psychotherapy can make a huge difference. In one very good study done in Pittsburgh, where I trained, even monthly sessions dramatically reduced the rate of depressive relapse amongst older people who had responded to treatment with medicine. The thing about treating depression in older people is to make it successful, more expertise may be needed. And we've heard Dr. Deligianides talked about ECT. I want to point out that ECT is still used in older people. It may be a better treatment for older people because it may work better and may be a safer treatment for some older people than medicines are in certain situations. And I put this slide up, which has a picture from the movie One Flew Over the Cuckoo's Nest, because that's what most older people associate with ECT in their mind. And this is a cohort of people that was around when ECT was done the way it was done in the 40s and 50s and 60s, when this, the time this movie depicts. And ECT is a very different proposition these days. So it's almost universally. We send a lot of people here actually for ECT. And they're often aghast when we first mention the prospect of it. But after they've had their first treatment, they come back to the office and say, that was no big deal, no sweat at all. Most of them say it's not as bad as going to the dentist. So in conclusion, I just want to say depression in older people is a huge public health problem. It may be the major threat to quality of life in old age. Late life depression presents some unique challenges. It's not a normal, expectable part of an aging. In addition to taking a toll on mental health, it takes a huge toll on physical health. That's critical for people to understand. It may be a different illness than depression in younger people is, but it can be treated just as successfully, although it may take more work and may be harder and may require more expertise, but treatment does work. We have some information about this on my practice's website. If you're interested, you're welcome to go look there and see what you could find. If you don't have time to write down the URL, if you just remember Moak Geriatric Psychiatry and Google search that, you'll get there. And with that, I'll close. I think we've run over a little bit, but hopefully we have time for questions.
Thank you very much. Me and technology. Let's see here. Right. It's now my really great pleasure to welcome Dr. Pata Tsuyamoto, who has come this evening to share her personal journey about doing well and feeling hopeful. She is an independent feminist scholar, a writer, an educator, and a mental health activist. She has a PhD in education from the University of Pennsylvania and did her research on multicultural education and issues of race and racism. She has spoken and written about her struggles with depression and is currently working with Christina Chan on an edited book about Asian American women and mental health issues. She is a volunteer for Families for Depression Awareness, and in March 2009, she was profiled in an article in Psychology Today about managing one's depression. When not doing scholarly work, Pata is an artist, an avid cyclist, and bicycle riding instructor. It's really a wonderful pleasure to welcome Pata. Suyamata.
All right, this is the first time I've done PowerPoint with this, so we'll see how it goes. I first wanted to introduce myself a little bit more. As was mentioned, I do have a PhD in education in reading, writing, and literacy from the University of Pennsylvania. I have a master's degree in education from Stanford University and a bachelor's degree in English with a biology minor from the University of California, Berkeley. I've taught graduate and undergraduate level courses at the University of Pennsylvania, Arcadia University, Bryn Mawr College, and the University of Massachusetts in Boston. The courses include things in multicultural education, Asian American studies, secondary ed, teacher research. I'll get that. I can do that. Hold on. Got it. I did it. Yes. Okay. Thank you. I'm also an artist and a jewelry designer. I'm a writer and independent scholar, and as mentioned, I'm working on a book on Asian American women and mental health, and also one on healing and writing. In the last 5 years, I've become an athlete. I have cycled an average of 4,500 miles a year, and for the last 4 years, I've done an AIDS charity ride, which is 125 miles in one day. I'm on the organizing committee for that ride and mentor new riders and help them figure out how to train and that kind of thing. I teach people how to ride and maintain bicycles. I'm a certified instructor with the League of American Bicyclists. I'm a healer and a Reiki master. I'm a mother of a 16-year-old daughter who is doing well in a private school in the Boston area. And I've suffered with major depression disorder, recurrent and chronic, and PTSD since I was 12 years old. So let's see, a little bit of family history since that was talked about. My mother was bipolar. She had psychotic episodes as a child. I remember the church ladies would come when she would decompensate to take her to the hospital because my parents were divorced, and then they'd call my father and we'd go there, and it was very traumatic. And it was a very chaotic childhood in a lot of ways. I remember one time the church ladies came and my sister and I were standing there and they said, "You look so stoic." Now I know I was dissociated, actually, and that it was, much more, I much more needed someone to say, "Excuse me, aren't you hurting? Don't you want to cry?" But, they were all about being stoic. My father's family, my sister, my aunt, my father's sister, committed suicide. My uncle's been hospitalized, and my father also has suffered from depression. So I have it genetically coming and going in terms of predisposition to depression. That's me, the baby, a long time ago. 1961, I was born, and those are my parents. And I have, as I said, been suffering with this since I was about 12. And for me, it has been chronic. I have not remitted, actually, to use the word. This is a junior high school picture. And my first memories of being suicidal are when I was about 12. I remember sitting at my mother's desk, which was this huge executive-style desk in a tiny study, and looking out the window at the snow falling and thinking, I want to walk out to that snow and die. I was 12. Okay. And that's me. That's my senior picture in the 70s, late 70s. As a senior in high school, I was hospitalized for the first time for committing suicide, for attempting to commit suicide. I was being interviewed by my colleague Christina about this experience, and I realized I remember very little about it in some ways. Like I don't remember how I got there, but I do remember, things about the hospital, the fact that the windows opened 6 inches and it was locked and all that kind of thing. Now, I was a senior. It was first semester of senior year. I was hospitalized on January 2nd. So my grades for that first semester were all W's, which don't look very good on college applications. So it sort of disrupted this whole time of my life. It was that. Up to that, there were a lot of stressors, obviously. It was transition time, going to college. I was at a very, I went to Newton North High School, which was, at the time in honors classes and all that kind of stuff. A lot of pressures involved. And I think that, that moment for me was sort of a critical time, and I became very depressed. As a young adult, I had bouts of depression. And, I continued sort of having depression and then being, all right for a little while and then having another bout. And then about 15 years ago, I had a major crisis. I was in graduate school but I had a 2-year-old daughter and I was getting a divorce and finishing my dissertation and my mother died. Boom, all at once, which really sent me into a spiral downward. Now, I remember working on my dissertation at the final end game, and I would literally cry an hour and write an hour, and cry an hour and write an hour. I did finish it, though, so that was the good news. I was a single mom for part of that time, and that was also a big stressor. So there's a lot going on that made this time very difficult. And at some point, I had to leave my job. I could no longer function. So what did I do? How did I cope? How do I maintain any hope? What do you do when you're at that low point? And first, I want to say there's no magic bullet. A lot of people think, I'll just get an antidepressant and then that's it, end of story. Well, it's certainly not the case for me. I have treatment-resistant depression, and I'll talk about that in a minute. But so there's not one way, one approach that worked for me. It's always been multifaceted for me. That my health and my depression is actually this sort of relationship I have with it. And I have had to be persistent and vigilant. It wasn't just a matter of doing something and then being able to be done with it. It's been this journey. And I think as one of the speakers mentioned, I think I did have gained some wisdom as a outcome. So what do? I do use Western approaches. I've had psychotherapy, and I've had good therapists who have literally saved my life. I would say that my therapist now, who is a fabulous therapist, has saved my life on at least a couple of occasions. I've had some very poor therapists as well. And, when I talk to people who are struggling with depression, particularly for the first time, I say, interview your therapist. Don't just say, okay, walk into the office and that's it for me, because it's a relationship. It's very important. And I had a therapist once. I was transitioning from one therapist to another. It was a new relationship, and it went into a suicidal spiral. I called him on the phone and said, I'm having a really hard time. And he said, he kind of brushed me off and he hung up, and then I called him back and said, wait a minute, I'm having a really hard time. And he said, I'm too old for this. If you want someone who can take calls, at emergency calls, you need to get a younger therapist. And he terminated me on the phone when I was suicidal. So finding the right therapist is very important. One of the things on my list, I have a list of things I bring into the therapy office when I first go in. And one of them was, do you take emergency calls? Because I'm not going to go with you if you don't. Because, So I also do psychopharmacology. Again, finding the right person has been critical. I had one psychopharmacologist who I literally felt like he wanted to get me out in 5 minutes. He was getting paid for 15, but 5, quick. get her out. And I was on the same medication that wasn't working for probably 4 years. And that's my own fault too, because I mean, I was not particularly empowered to say, wait a minute, this hasn't been working for 4 years. I just was kind of going through. He terminated me because he didn't want to take my insurance anymore. I actually think it was because he was frustrated that he couldn't make a difference. Because I do have treatment-resistant depression, which means that I think is it 3? I asked the doctors here, 3 rounds of medication that didn't work. But I might have been on hundreds of medications. I once went through the family doctor's list of all the psychopharmacological medications, and I had been on about at least half of them at one time or another. And now there's more, so probably not so much. But so this treatment-resistant depression means that psychopharmacology is very important, finding the right person. And when I got kicked out for not having the right insurance, I found a psychopharmacologist that works fabulously. And the first time he actually remembered my life story, I was like, you're asking me a question about my life? Wait a minute, you're not going to try to push me out? I was astounded. But it's made an important difference in my life in that he thought outside the box. He tried to figure out what would work for me. He gave me some medications, and although they are not a magic bullet, they definitely raised the bar for me and make me able to do things like be here tonight. So I do a bunch of complementary approaches, including acupuncture, Reiki, which is an energy healing, a Japanese energy system. I am a Reiki master. I actually do Reiki for other people as well. Different kinds of body work, shiatsu massage, more classical massage. I've worked with a sound healer, with voice and being able to express my voice. I've done various herbal remedies, including as well as supplements, things like the fish oil and that kind of thing. And I also, it's not mentioned on here, but I do have a light box because I also have seasonal depression. It gets worse in the winter. So what else do I do? One thing I do is I cycle. I mean, they talk about exercise, but I used to not exercise. And when you're in the depths of the depths, it's very hard to get yourself out of bed, never mind exercise. But I actually fell in love with a cyclist, and he kind of got me on the bike, and I decided that it was really my thing. And as you can see, I've done a lot of different things, as I mentioned before. But it is very much a part of my treatment. It's not optional. So when I have things like asthma issues, it affects my cycling, which affects my depression. It's all linked together. It's not like, I can just not cycle, because I actually need to do this to keep healthy. I also do creative things. Again, this is part of my treatment, I think. I write. I'm a journal write. I have so many journals and boxes. I don't know what my daughter's going to do when I die. It's ridiculous. I have a blog. It's actually about cycling. It's called thepolkadotjournal.blogspot.com. And I blog about that. But I blog about life. I don't really blog about cycling. I blog about things like pushing through. Like, when do you push through and when do you pull back? And particularly as a person's depression, that's a very important question. When do I tough it? And when do I say, wait a minute, I need a break? I'm working on articles. I've worked on a number of articles and various book projects. And I also am a collage artist. I'm very interested in interactive pieces of art. I have a suitcase that I'm filling with medicine bottles, all of mine, and I'm putting things in them. That is this interactive piece about what it means to be struggling with a chronic depressive illness. And in that piece, it's called Mother's Baggage. So it's sort of related to that as well. I also do joy design. That's a picture of something I designed, for lack of other things. So spiritual practice. Again, this is so important to me. I mean, I can't imagine not doing my spiritual practice. And the spiritual practice has been critical in staying alive. Because being able to say, okay, there's something bigger than me. I don't know what that is exactly, but it's bigger than me. So I have prayer practice and rituals and meditation. I have something called a life box, which is a box, a literal box, with things in it to remind me why I stay alive. And one of the things in it is a picture of my daughter, who her birth announcement. There are messages from friends. There's all sorts of things, including a set of cards that I made, which are coping cards. So if I can't figure out what to do and I feel like crap, I take one of them and do that, whatever it is. Because one of my things my therapist has told me, I truly believe this, is do it anyway. You don't feel like it, do it anyway. Because on some level it registers. Okay, you're important enough. You're okay enough. You can do this. You can write a letter or talk on the phone or whatever. I have a list of coping strategies. I actually typed out a list of coping strategies for myself. And these are the categories of them: support and connection, comfort, healing, spiritual, expressive, and distraction. So support and connection is like calling a friend. Comfort is, like making a cup of tea or taking a bath. Healing I've done a lot of self-help books, things like cognitive worksheets. And I'll do a cognitive worksheet, particularly if I'm in a negative thinking pattern. Spiritual, I mentioned those things, the meditation, that kind of thing. Expressive is all the art stuff I do. And then distraction, go to a movie, listen to some music, get out, do something. And I actually have the list of things. And when I really feel bad and can't remember what to do, because when you're depressed, you cannot remember that you should call a friend. And you can't even remember who would be willing to listen to your stuff, because not everyone is willing. So I have a list of my peeps, right, that people I can call. And then there's pacing. I have to pace myself. I'm living with this chronic illness, and I can't, at this point in my journey, I can't do what I did before. So I have to pace myself. So like today, I didn't do anything because I knew I was coming here tonight. So and if anything, one message I want to say is that you need to speak your truth about this, particularly to your family. My mother, when we were growing up, she was sick. What was that? What did that mean? She was sick, but we knew she was not well mentally because she would talk to herself and think that people were in the house and tell us, all kinds of things that were not true. At least we didn't think so. Of course, we were young, and so that was that kind of, like, what do you believe? The sky is green because your mom's saying so, or that it's blue because you're looking up? It's hard to know. So I vowed when I was, growing up and when I had a child, that I was not going to have a secret from her. That I was going to tell her, regardless of her age, that I had this illness. And that meant not burdening her, but explaining. So when she was 3 and would say, why can't we go? Oh. I'd say, because mommy has an illness that makes her sad. And that sadness keeps me from going out. Now let's make a plan, and we'll, plan to go out in an hour. Give me an hour, and then we'll go to the park or whatever. And the other thing is that kids think it's all their fault. I thought it was all my fault when my mother was sick. It was my fault. But it wasn't my fault. It's taken till now to be able to say, it wasn't my fault. Guess what? But you know what? I wanted my daughter to know that way before I knew it. So I would tell her, mommy's really sad, but it's not your fault. And it's not your responsibility to make me happy. This is a picture of her as much younger. Obviously, that's not 16. But she had dressed up as a clown to make me happy. And it was really sweet. And what I said to her, though, is I said, Nico, it's really nice that you did this for me. I really, really appreciate it. And I love you so much. But it's not your responsibility. It's okay. Mommy has people to help take care of her. Because it's not your fault that I feel this way. Neither is it your responsibility to take care of me. So I was very clear about that, and I feel like if you don't speak to anyone else and you have depression, talk to kids. They know. What do you think? They don't know that you're depressed? You didn't get out of bed. They know, but they don't have language, and they think it's their fault. The other thing is, just being able to be honest with family and friends, and not that you can be honest with everybody, because there are people that don't want to hear it, there are people who don't understand it, there are people who you can't be honest with. But to have a few people is really important, because I feel invisible when I'm feeling really bad, and I have to go, oh, I'm fine. Yeah, I'm fine. Really, how are you? Fine. No, I'm not fine. So I need someone to say, listen, I'm not fine, and this is how I'm feeling. And just witness it. They don't have to do anything. People think they have to fix it. oh, well, the worst thing you can say, at least I think, to a person who's depressed is, oh, just cheer up. Why don't you just go outside, listen to something funny. Well, that might work, but it's like, that's not what I need. I need you to hear that I feel bad. You don't have to do anything. Just be with me. And then for me, I have done some public speaking. And I volunteer, as was mentioned, with Families for Depression Awareness. Their site is familyaware.org. I would invite you to check it out. They have profiles, they have information, they have suicide prevention information. They have a lot of wonderful things. I've spoken at a number of conferences recently, particularly about Asian American women. And I've done various media things, including Psychology Today. I talked to Boston Globe. And for me, I seem to kind of go to the thing that I'm struggling with and teach about it, because I feel like I was born to be a teacher, and that's really what I've done the rest of my life. I've been blessed. I've taught everything I've ever loved to do, and some of the things that I hate that are true about my life, such as being depressed. But it is important to speak out. So one of the things I'm working on is called the Breaking Silences Project, and this project is there's a statistic that Asian American women ages 15 to 24 have a higher rate of suicide than Caucasian, African Americans, and Latinos in that age group. So to put a face to that statistic, what we're doing is collecting stories. Not research. This is not research. This is a face to stories. And we're collecting stories. So if you are or know someone who is Asian American woman who has suffered with depression and anxiety, or considered suicide, has emotional issues, or as diagnosed with a mental illness, and you want, if you are fit that category, to break the silence, contact us, because we're collecting these stories right now. And breaking the silence is really important. I think stigma is really alive and well, unfortunately, and we have to resist that. As a woman of color with depression, I face stigma that in a world that often does not want to hear me, does not want to hear the story, does not want to hear the fact that, things like, that racism, for instance, can affect how I feel. I grew up in a community where people would call me Chink, and I would turn around and say, if you're going to call me a name, at least get it right. I'm Japanese American, not Chinese American. So, so these kinds of things, but that's putting a face on something that's really hard. There's a poet, Audre Lorde, who talks about what it means to speak out, even though the world doesn't want to hear your story. And I'm going to read from her poem. It says, for those of us who are imprinted with fear, like a faint line in the center of our foreheads, learning to be afraid with our mother's milk, for by this weapon, this illusion of some safety to be found, the heavy-footed hope to silence us. For all of us, this instant and this triumph, we were never meant to survive. And when the sun rises, we are afraid it might not remain. And when the sun sets, we are afraid it might not rise in the morning. When our stomachs are full, we are afraid of indigestion. When our stomachs are empty, we are afraid we may never eat again. When we are loved, we are afraid love will vanish. When we are alone, we are afraid love will never return. And when we speak, we are afraid our words will not be heard nor welcomed. But when we are silent, we are still afraid. So it is better to speak, remembering we were never meant to survive. That's where I'd like to end. And thank you for coming out tonight.
They're wet, but they are from the heart. Thank you for sharing your story. It was quite significant for us all. Questions, a time for questions. Any questions for any of the speakers? You got to have some. Okay. Who doesn't need their glasses to see their question?
My question is for Dr.
Mhm.
My question is, you spoke about your dark periods.
Mhm.
Do you think in that time you could have made an informed consent decision about when to go to therapy? Repeat the question.
Sure. She was asking me about ECT and whether I could make an informed decision at my darkest moments. I'm not sure, actually, to be honest. I think the thing that is true, it was approached to me because I have treatment-resistant depression to try ECT. At the time, I was working on my dissertation, and I thought if I lost my memory, that would really suck. Excuse my language. Really. Like I've been working 10 years on this thing, So I decided that it was not for me at that time, and that I would, I do think that this is where also family and friends come into play. Depression is not it's often, I think, perceived as a very lonely disease, but if you have a network and you can, reach out to those people and those people are responsive, it can make a big difference. Because I would never go into that decision by myself in my darkest moment. Is there anyone else who wants to? Sure.
Okay, God bless us now. This is actually came up in the course of Dr. Rothschild's talk, but it's actually for all psychiatrists on the panel. There's a recent New York Times article, the one where he's working.
Can everybody hear?
I can talk loud.
Okay, go for it.
There was a recent New York Times article in which a psychiatrist was talking about basically bemoaning the demise of his talk therapy practice and about the conversion of him to basically a psychopharmacologist from having been a psychiatrist. So what I wanted to hear, from past talk, it sounds like, and from all of your talks, treatments for depression are multimodal, across many different descriptions of the person. So, what are some of your views about this demise, and are you interested in sort of fighting against it and maintaining a position for psychiatrists, talk therapists in particular with respect to fighting over
I'll take it. Yeah. So for those of you who didn't see the Times, there was a really depressing article, if you will, about a psychiatrist who was bemoaning his fate, that he had ended up doing medication visits in those very small, brief 15-minute visits, and that his world had come to that. It was a little bit of an interesting article in that when people spoke to his patients, he was an old school guy, and most of the patients actually found him somebody who at least they could talk to, and he was interested in them and could at least communicate interest to them. And he was even more depressed when he found that out, because he said, that's interesting people, I can't even remember their names. So it was a very sad article. And I do think that the profession has been under tremendous strains in the last few decades, in part inflicted by the outside and in part, frankly, self-inflicted. The psychiatrist in the article made a choice to live his life that way, in part economically driven. And I certainly hear a lot of moaning about the fate from psychiatrists and other professionals and doctors, but I think you take one step back and you look at the world around us, and there's a lot less to complain about. Certainly, a lot of our patients suffer more. I strongly believe in a relational basis to care, that particularly with depression, one of the interesting things about it is how important the relationship is to treatment. There was a really interesting study done where they compared all these different treatments for depression, cognitive therapy, interpersonal therapy, medications, and placebo. And for mild and moderate depression, the treatments did pretty much the same. For severe depression, the meds seemed to be a bit more important. What was really interesting was that the best psychiatrists did better with placebo than the worst psychiatrists did with medication. When they looked to try to find what was those differences, it's the things you imagine. People you can confide with, share discussion with, talk to. And I think that's essential even in the briefest of visits. I'm amazed when I work with patients. I do clinic, which I like, is Democracy in Action. I also see patients in my office here. But people start talking the moment I meet the lobby, and we're talking on the way back, and they're the best goddamn 15 minutes you've ever seen. But there are things that you can do from a therapy perspective that have certain aspects to them that you can't cram into 15 minutes. So I do think my patients feel understood. I do try to take those emergency calls. I am present, I am there, but there are aspects of a discussion and therapy and expanding the discussion that you simply can't do in those brief times. Even there, I try to get around it in brief encounters. So if there's books to read, online to go, I'm always interested in hearing what the patient has been doing to work on the depression, because it's so disempowering to just sit there and expect the medications to do everything. So you really want to get everything going and engaged. And I am really curious about how to make it great. You know, here we really try to have psychiatrists that are interested in the whole patient. I will go to Dr. Rothschild often if I'm stuck on a psychotherapy issue. He's no slouch in that domain either. And we try to make sure our psychiatrists do have some time to do therapy as well as pharmacological practice, because we want people that understand the whole of the patient. But there has been, you know, an insurance-driven push to narrow the visits. But I don't think it's simply to say that we're helpless in the face of it. I didn't find a very satisfying article, response to that article, to be frank. You know, it's something we need to work for and fight against. I also do think that we've gotten more collaborative, both with our patients and with our other non-psychiatric colleagues. So working as a team. I'm still old school, you know, so I do like to try to bring as many skills and things I can to the therapy session. But it is practical, I think, to look at a division of labor, working collaboratively with other therapists and working together, but hopefully with a respect for a multifaceted approach, and particularly respect for what the patient comes up with in terms of trying to beat this darn thing. So you know, those are some of my thoughts. But I really do think good pharmacological care is relationally based still. I mean, you have to tell your story to somebody. You have to trust them. You have to go on this often long journey together. So you hopefully like each other and work with each other. And they've done research on this. The best predictor about the outcome of therapy is whether you like the therapist after the first 2 sessions. So same for the medications. So, you know, there's still a lot to be had there, but I do think we have to work together to keep the opportunity for not just narrowing this to simply a psychopharmacological approach, my own view, although I keep waiting for my friends in the laboratory to come up with better and better medicines, and they're working on that too. So some thoughts. I don't know, did you have anything to add, Tony?
When I saw that article, I got angry for many different reasons. One of which, I thought that articles, the psychiatrist there oversimplified the complexity of the medications, and the idea that he could do this in 15 minutes or less was a little scary. But you know, the field has swung from when I entered psychiatry, I was trained as a psychotherapist. Most psychiatrists, that's what they did, and there were only some psychiatrists who also combined antidepressant treatment with psychotherapy. Now we've swung the other way, where psychiatrists are, almost all of them will be prescribing medications, and some do psychotherapy. So I don't think any of this is good. And as Dr. Brown points out, some of this was driven by less coverage for psychotherapy by insurance companies than there was 20 years ago, which is most unfortunate. I still think the best treatment, well, as a psychopharmacologist, people don't live in a bubble. They're just not you have to know the person, that there are choices to be made regarding medications, and you have to understand the person to make the proper choice. And of course, first of all, I don't see patients for 15 minutes. I never have, and I hopefully never will. I mean, I won't do it. I mean, it doesn't make any sense to me. So, you know, in the session, I'm not just slipping somebody an envelope with instructions when to take their pills. I'm talking to them and understanding them, and I think that results in better outcomes.
Another question?
Yes.
Yeah. I just wanted to
comment that I thought all the presentations were wonderful and that they all come together and give a very nice picture. But I was especially impressed with Dr. Moak's presentation, and I think this is an area that is sorely neglected. Having worked with an elderly population for years, I never heard any of this, none of it. And I just would encourage, and obviously you're doing this in a very concerted way, but I would just say, get the word out.
Great, thank you. You had a question?
Yes, Dr. Manitas. Barry. One of your earlier slides, you touched on the impact of alcohol along with medications. So if you have a patient that is in depression, taking antidepressants, who is an alcoholic, were you saying it is better to keep the alcohol at a steady level during that point in time? Or my notes show that the reduction of alcohol during treatment could have a negative impact. Is that correct?
So to clarify that slide, is that what's critical is to understand how they impact each other. So if there's alcohol abuse or alcohol dependence, how those substances, any substances, can affect the mood. And also substances can affect medication, metabolism. There's so many effects. So we always want to look at the effects of any medication we're giving with the substance that's being used, and also the impact of the substance on the depression. We want to be able to treat both the depression and if there's alcohol abuse or dependence, which is impacting functioning, together. So there are a couple different schools of thought. Some, I believe in the past, would say if there's alcohol dependence that continues, that treating the depression is a moot point. It'd be very difficult to treat the depression if alcohol use does not decrease. I think where we are now, where the research is showing, is that we must do a two-pronged approach. We must treat both together. So reducing alcohol use would benefit the depression treatment. And we want to aim our treatments for both. So we treat with an antidepressant or whatever treatment that is for that modality, and then also the addiction piece. Because these are, you can't tear them apart. They're so linked that the treatment must be integrative. Does that answer your question?
Yes.
Okay, you're welcome.
Any other questions? Yes.
Dr. Moak, I definitely agree with when you say that depression is a family burden. But how do you go about when we see all the symptoms from family members and they deny it?
So the question is, she agrees that depression in older people is a family illness, that it has an impact on all family members, and it's impressive to see over and over again. But what do you do when everyone in the family sees the problem, but the old person who has the depression doesn't see it and resists everybody's pleading to get some kind of treatment? If I knew the answer to that, I'd be... The answer is, this is really where you can't fit psychiatry into 15-minute office visits, because helping family members, working with people and working with their family members to help them make good decisions. And actually, you commented about the importance of networks. So the trick is you really have to get to know the person. You have to build up some trust. You have to help the family. You have to know the family members and understand how the family works, how they communicate, how they solve problems together, how you can advise family members to then influence a patient who needs treatment to make the right decisions and have the treatment. And that's not there's no easy fix to that. So we have an article on our website, for example, how do you get an older person who won't go to see a psychiatrist to go to see the psychiatrist? And it provides some helpful tips about what you can do to try to approach that. One of the things we do, frankly, with people that are cognitively impaired and can't really make good decisions and are in their own way, I wouldn't say we encourage people to lie, but we encourage people to not share 100% of the truth. So the name of my practice, for example, isn't the Moak Geriatric Psychiatry Associates. It's the Moak Center for Healthy Aging. When an older person comes to the office, nowhere will they see the word psychiatrist or mental health. Won't see it anywhere. And usually they get it. By the time they spend 5 minutes talking to me, they get it that I'm different than most doctors. But by that point, it no longer matters. They've been able to kind of connect with them and make them feel okay about being there. So it's really a foot in the door kind of phenomenon. But there isn't an easy answer, and it's really tough. And sometimes you have to use, what Bill Clinton used to refer to as tough love. Sometimes you have to be willing to let people get worse before they'll be willing to let you help them get better. I mean, every patient and every family is going to be different. And so there isn't really a good, easy answer, but it's a huge, huge, huge problem. And I can tell you, if you're going through this, you're not alone. There are millions of American families dealing with this problem as we speak.
Yes. I guess it's more of a comment than anything. I mean, following up on what you were saying, get the word out, and the stigma, the stigma is still very much alive. And you just need to normalize it more. Like with the aging population, of course, they come crazy into psychiatrists, but they weren't, they're never going to admit that they're having problems. So, I mean, like the way that Pat just spoke tonight, I don't know if you get, older people who go to senior center and talk about their experience or, just, I guess I just want it more out in the awareness. My brother recently died. He struggled many, many years with mental illness. Tried to do that so many times. And, it definitely was the family illness. I've been affected very much by depression. And if I go through a hard time, if somebody hasn't seen me in a while, and they ask, well, how was your summer? All cheerful and everything, I actually do tell them the truth, because I feel like the more that I speak up about it, the more they're going to feel safe speaking up about it. Because they have to know that people do go through this, and I'm not going to hide and pretend that everything is fine. So, but the whole thing about it being a family illness, like I just feel like, and it was a while ago, and there's been a lot of development and changes since my brother was first diagnosed, but I just felt like we weren't really kind of included in like how should we tell him, how should we be a good support to him. It seemed like there was a lot of missing pieces, and when he would go to the hospital and have a really successful time with group therapy, then they just sort of let him go, and there was no real follow-up. Like you might want to go and see this person, or maybe there's a group that you might want to. It's never really kind of, walked away.
Yeah, I think there's a lot of work to be done in all of mental health, and I think it's all of us have to play a role in making it much more public, making people making it more of part of the conversation of American life, and people understanding that when somebody goes into the hospital because they're having surgery, people send them cards, and when somebody goes into a psychiatric unit, people don't send them cards. And an illness is an illness, and we have a lot of work to do as a culture, as a society, and everybody plays a role in that. So, one more question.
When you ask that question, point with family member, they're not going to hurt themselves, but they are hurting others. What can you do with it? Can you force them to get help?
So, we rarely, we'll see that.
I had no idea how this was going to be, how they were
It
going
would
to
have
present
been
it.
easier to follow if you saw them.
Oh.
You know what I mean?
So it's a difficult question, and in some ways easy to answer, like what are the laws, which really don't answer the question. Yeah. So legal recourse is pretty limited, It does involve primarily with depression, it's mostly risks of self-harm. sometimes about self-care, and rarely risks of violence. But forced treatment is a very restricted intervention to respect the rights and civil liberties of individuals. So, you can always ask. There are commitment laws if someone's imminently at risk, and we have emergency services that are really adept at using those laws, know how to use them, and the police as well. But it's often not much of an actual recourse for families. You can get access to courts if you really think someone's at risk, but it has to be so imminent that it's usually not the way we go, or family members can go on occasion, and then you'll need help with that. Sometimes you'll see it with a long, slow decline, where people really aren't taking care of themselves. There's probate court and guardianships. Maybe with the elderly, you might see that more frequently. Gary might speak to that in elderly patients. But for other family members, we're not helpless. Often the question comes up, can we use the courts? And the simple answer may be no, but it doesn't mean we're helpless. And how to get help. It has gotten better in my lifetime. Psychiatrists may be a bit dense and sometimes arrogant, but we sometimes learn a little bit, and we have learned from families, and much more of an effort to bring families into the discussion. There still are confidentiality rules and privileges, but we don't want to hide behind those. So often there's much more of an effort to encourage the patient to let us bring in the network, let us bring in other. And it's more similar to trying to treat other significant illnesses. So there's been some change in how families are brought into the discussion, but the most difficult area probably still is these emergent situations that involve legal intervention. When I work with a patient where that's been done, often there has to be some degree of repair and understanding about how it got to that, and so we can move on together. But it's a very difficult area. You're limited. I wouldn't say quite nothing, but it's a limited area to go that route. So, okay. Yeah.
Is there some person or some agency that a family could call?
Yeah, so for the elder services and things like that, they're often, you want to comment on probably the scenario where people see it most often is with